being here. We'll be recording the session. As everyone I think knows, this program is funded by a grant from Pfizer. So we're going to start as we did last time with our hot topic. This is based on these surveys we did several months ago when we asked what you guys wanted to learn about most. So Dr. Ryan Ungaro is going to talk to us first about moderate to severe Crohn's disease.
All right. Well, thank you, Zoe. Thanks, everyone. This is a very small topic, moderate to severe. But I'm going to do this is supposed to be a high level, just kind of quick hits kind of thing for the next like 10 minutes or so. Ask any questions, interject. So when we talk about moderate to severe, those are my disclosures. When we talk about moderate to severe Crohn's disease, what do we mean? How are we defining that? So I think the key thing when you're thinking about Crohn's disease as well as ulcerative colitis is that you want to think about two general concepts when you're seeing a patient. One is disease activity, which is how is this patient feeling right now? How much inflammation do they have this moment in time, the person sitting in front of you? And then you want to marry that idea with also the disease severity, and that's incorporating more risk factors. So for disease activity, classically, this is from clinical trials, but no one really uses this specifically in clinical practice, but just for reference, Crohn's disease activity index, moderate to severe, these are the scores, and you can think of it as moderate being more some mild, some weight loss, some milder symptoms, maybe some tenderness on exam, no obstruction, but elevated inflammatory markers, SCS-CD score typically above 6. And then severe cases is CDAI greater than 450, and these are patients that are obviously more systemically ill, may have evidence of complications like strictures, fistula, et cetera, and markedly increased CRP for inflammatory burden. But I think not just how a patient's feeling, you have to also take into account what their risk factors for progression are, for how likely are they to develop complications of disease. Because you may have a patient who feels well, but has risk factors for having more aggressive disease course. And this is from the AJ Care Pathway, published by Bill Sanborn now almost a decade ago. But in general, the high-risk features we think of for with Crohn's disease are young in diagnosis, extensive anatomic involvement, so someone with jejunitis, pancolitis plus ileitis, more certainly upper tract disease, perianal disease or severe rectal disease is a poor prognostic, deep ulcerations on your colonoscopy, particularly in the ileum, prior history of surgery or prior history of strictures or penetrating complications such as internal fistula or abscesses or phlegmons, also known as inflammatory masses. And so these high-risk features, if you have these are also things that should trigger you to think about a more aggressive approach to treating patients. And this was a schematic that we proposed with Dr. Agarwal, Dr. Spencer, Dr. Collinbell, where you think of the patient's disease activity that I was just mentioning, where you have moderate to severe symptoms, but you want to marry this with disease severity, those risk factors. So if you have someone who has low risk factors and mild disease activity, this is someone who's lower risk of progression, and this may be someone you can do a more traditional step up or monitoring approach to. But someone who has potentially low disease activity is feeling well, but has high risk factors, you want to treat more as a moderate to severe risk of progression. And these are patients that you want to think of for earlier targeted therapy, going straight to a biologic or other targeted therapy if you're falling into more moderate to severe risk for progression. So how do we then, we decide, we see a patient, we decide that they need advanced therapy. What are some of the data for which therapy we should choose? We obviously have an expanding armamentarium in Crohn's disease, which is a great thing, but it sometimes causes some confusion for us because we have more therapy. So which therapy do you choose for which patient? So I'm going to talk about bio-naive Crohn's first. So generally speaking, this is patients who have not been on a TNF, and then biologic exposed, which generally patients who have been exposed to a TNF inhibitor. So first, just a few studies, clinical trials that I think are very important. Let's landmark studies. This is the SONIC trial where they took bio-naive, relatively early Crohn's disease, moderate to severe patients, and they randomized them to azathioprine, an immunomodulator, infliximab alone, or infliximab plus azathioprine. And you can see here that infliximab alone outperformed azathioprine, but the combination of infliximab plus azathioprine outperformed both of these arms. So combination therapy, still some of the strongest data for us in moderate to severe Crohn's disease in bio-naive patients. Now, there's been newer drugs, and we also have injectable drugs. Obviously, infliximab is IV. And so two drugs that are frequently used in moderate to severe Crohn's disease are adalimumab, or ADA, and ustekinumab. So adalimumab is also an anti-TNF, and then ustekinumab an anti-IL-12/23. And this is one of the only head-to-heads of two biologics that we have in Crohn's disease. The Seaview study, you may recognize the first author here. And this is randomizing bio-naive Crohn's patients to either ustekinumab or adalimumab. And essentially what you can see is across most, if not every single endpoint, whether it's clinical remission, corticosteroid-free remission, also endoscopic endpoints, that both adalimumab and ustekinumab essentially no significant differences between the two drugs. So in a bio-naive Crohn's patient, a little bit of dealer's choice between adalimumab or ustekinumab. Newest kid on one of the newer kids on the block that is a player in the bio-naive space for Crohn's disease is risankizumab. This is an anti-IL-23 therapy. So in contrast to ustekinumab, this targets just the P19 subunit, so it just gets IL-23 and not IL-12 plus 23. So it's a little bit more targeted. And this is some of the data from the Advance and Motivate trials, where you can see that compared to placebo, risankizumab, this is for induction data, had higher rates of clinical remission in the 40+% range, higher rates of endoscopic response also in the high 30s. And then similarly, whether you, in a group of biologic exposed, you also saw efficacy compared to placebo. So anti-TNF, anti-IL-12/23, anti-IL-23. There also is data for vedolizumab in bio-naive patients, but just for sake of time, I'm not showing that here. So we have all of these drugs at our disposal. We only have the one head-to-head in the bio-naive patients. So in the absence of head-to-head data or biomarkers, how can we get some educated guess or some inkling of information of data to kind of help us decide which drug in which patient, and how do we rank these drugs? So there's something called network meta-analyses. You all might be familiar with it, but briefly, this is where you look. You're not really supposed to compare across clinical trials, but in network meta-analyses, you're doing that, and you're anchoring on the placebo groups across trials, assuming that the placebo groups are similar, and then trying to compare across trials through some statistical methodology to compare the drugs to each other. And so in this network meta-analysis that was published in Gut recently, you can see here that what came out on top for bio-naive Crohn's were risankizumab, infliximab, adalimumab, and ustekinumab. And you can see all relatively similar effect sizes. Also down here, vedolizumab as well, but you can see maybe a slightly lower effect size, which I think is consistent with the clinical trial data and our clinical experience. So whether it's infliximab, anti-TNF, IL-12/23, IL-23, or vedolizumab, they're all reasonable options in a bio-naive patient. But this data suggests that anti-TNF or maybe anti-IL-23 or anti-IL-12/23 would be preferred over vedolizumab. So what about bio-exposed Crohn's disease? So this is generally speaking anti-TNF exposed patients. This is a lot of patients we see particularly at Mount Sinai. What are the data there? So first, I'd just like to say, there's a new player when you're thinking of bio-exposed, particularly a TNF failure patient, and this is upadacitinib, a JAK inhibitor. It's an oral therapy. You're all probably familiar with it. It was first approved in ulcerative colitis. Now it's approved in Crohn's disease. And this therapy, this is the data from the Crohn's trials, because of a black box warning for risk of VTE, skin cancer, and cardiovascular events, is relegated by the FDA to second line after TNF exposure. So you can really consider it in a TNF exposed patient. And you can see here the data compared to placebo, that you have superiority across multiple endpoints. So again, network meta-analyses coming up in bio-exposed patients, and by the same group. And you can see here that when you look in bio-exposed, risankizumab, upadacitinib, and also adalimumab, and I think this is partially because if you're exposed to infliximab, the reason for failing, particularly if it was used in antibodies or immunogenicity, you can recycle an anti-TNF. And even in a patient that has mechanistic failure, you may have a little bit of a recapture with retreatment of TNF. But all of these agents seem to be preferred. Ustekinumab also performs well in anti-TNF exposed, although potentially less so than these other drugs based on this network meta-analysis. And you can see here vedolizumab is crossing 1. So generally speaking, vedolizumab, if you're going to use it, using it early in a bio-naive patient is preferred. And then actually, this is hot off the press. This is just press release data, so we haven't seen the full data yet, the sequence trial. This was a Crohn's disease, moderate to severe, exposed to anti-TNF patients, randomized to risankizumab, an anti-IL-23, versus ustekinumab, an anti-IL-12/23. So some thought for various reasons that maybe risankizumab could be superior to ustekinumab. And so far, the top line data, and again, this is open label, we haven't seen the full data, but highly suggested that risankizumab has higher rates of clinical remission at week 24, about 60% compared to 40s, and also similar results with endoscopic remission. So with that data in mind, that probably puts risankizumab, at least right now, potentially above ustekinumab. Now, there's a lot of, you can see there's an absence of head-to-head data for most of these patients. So in the clinic, we oftentimes are including a lot of different special considerations. And this is where shared decision-making comes in, and also thinking about, can you kill two birds with one stone, or other potential considerations with your patients that would drive you to one drug or the other. So if someone's prioritizing convenience, this is where you're going to think about injectables or orals. Older patients, because of safety profile, lower risk of infection, potentially not necessarily anti-TNFs or the JAKs, but going for anti-integrin, anti-IL-12 or 23 or anti-23. Similarly, in patients with a history of cancer, in particular melanoma or lymphoma, you may shy away from the anti-TNFs. Solid tumors, just to note, this is a talk all in itself, but if you have a history of solid tumors, actually TNF has not been linked with recurrence necessarily. And then another thing to think about are diffuse extraintestinal manifestations. So anti-TNF, particularly if someone has arthritis, upadacitinib also is a good choice in this situation. And then if someone has psoriasis, thinking about the IL-12, 23 or IL-23 agents, because these are also approved to treat psoriasis. So thinking about dual indications. And then obviously, this is more, a complicated decision with any particular patient, where we think about efficacy, which I showed you some of those data, but we're also thinking about safety and the patient's personal risk tolerance, and then the patient's individual characteristics, comorbidities, any contraindications based on the side effect profiles, and then ultimately sitting down with the patient and understanding what they value, their risk tolerances, and what's their lifestyle to help you decide which medication for which patient. So in summary, it's important to incorporate risk stratification into decision-making for all patients with Crohn's. So even if patient's feeling well, if they have a history of complications like surgeries, fistula, strictures, et cetera, that's a patient you want to consider going to a more advanced therapy. And there's obviously a number of effective options for induction and maintenance in Crohn's disease that I mentioned already. Just to kind of summarize briefly, bio-naive, I think essentially all of these medications work reasonably well. Anti-TNF, ustekinumab, vedolizumab, and now risankizumab as well. It seems that the data probably favors, based on network meta-analyses, the anti-TNFs, anti-IL-12, 23s, and anti-IL-23s over vedolizumab, although in bio-naive it does seem to perform okay. And then fistulizing perianal disease, this is still where anti-TNF agents, I think, are the leading selection. TNF failure patients, obviously you need to take into account the reason for failure. Was it because they had immunogenicity and had antibodies to the drug, or is it because they failed the mechanism of the drug? And particularly if you had mechanistic escape, I think the data now suggesting risankizumab would be its preferred second line, although ustekinumab is still a good second line agent, and both of these over vedolizumab. And I think what we're trying to figure out where this fits is upadacitinib, new JAK inhibitor, where we've been using it in our multiple refractory patients, but perhaps this will move up in the algorithm after initial TNF failure. And then lastly, based on the SONIC data, immunomodulator is recommended in combination with the TNF, particularly in infliximab, where the immunogenicity rates are higher, and you can consider it also with adalimumab.